Hi students, I welcome you all to Obstetrics and Gynecology with Mackler. So in this module, we are going to discuss about the vaginal prolapse. So in the previous module, we discussed about the uretrocervical prolapse. In this module, we are going to discuss about the vaginal prolapse. So what do you mean by vaginal prolapse? See, uretrocervical prolapse is a condition where the uterus along with the cervix is going to get descended down. So it can descend either into the vagina at the level of the vaginal introitus, or it can lie entirely outside the vaginal introitus where it is known as procedentia. But vaginal prolapse is a condition where, because of the weakening of the supporting structures which is supporting the vagina, the vaginal wall is going to get weakened. So through this weakened vaginal wall, the surrounding structures are going to get herniated out. So the surrounding structures getting herniated out through the weakened vaginal wall is known as the vaginal prolapse. So basically, if you take into consideration the vagina has two important walls. Those are the anterior vaginal wall and the posterior vaginal wall. Right, as you can see in this image, the structure which you are seeing here is the uterus. This structure just anterior to the uterus is the bladder, and the distal portion of the bladder, as we all know, is going to be the urethra, and immediately posterior to the uterus we have the rectum. Right, clear. And the distal portion of the cervix is going to be the vagina. So this is the uterus, this is the cervix, and this is going to be the vagina. And as you can see here, the vagina has two important walls. So this wall is known as the anterior vaginal wall, and this wall is known as the posterior vaginal wall. So what are the structures which are immediately near to the anterior vaginal wall? So those are the urinary bladder and the distal portion, which is the urethra. And what are the structures which are immediately near to the posterior vaginal wall? Those are the rectum, and here you can see the cul-de-sac. So what is this cul-de-sac? These are the pouch of Douglas. So the space between the uterus and the rectum, the recto-uterine pouch, is called as the pouch of Douglas, right? And here the intestines will be present. Right, so based on this, we are going to discuss about the vaginal prolapse. So until now, are you clear with that? Right, vagina has two important walls, anterior vaginal wall and the posterior vaginal wall. Right, so now as you can see here, so this portion is going to be the cervix. So this portion is going to be the cervix, and this is the anterior vaginal wall, and this is the posterior vaginal wall. So vagina is basically divided into three levels, and these levels is given by de Lancey's levels of supports of the vagina, right? De Lancey's levels of supports of vagina. So they have basically divided this vagina into three parts, which is level 1, level 2 and level 3. So level 1 is the upper 1/3 portion of the vagina. Level 2 corresponds to the middle 1/3 portion of the vagina, and the level 3 corresponds to the lower 1/3 portion of the vagina. So upper 1/3, middle 1/3 and lower 1/3 of the vagina. So what are the structures which are supporting these each levels of the vagina? So the level 1, which is also known as the upper 1/3 of the vagina, is supported by the uretrosacral ligament and the transverse cervical ligament. Transverse cervical ligament is also known as the cardinal ligament or the Mackler's ligament. So the upper 1/3 or the level 1 supports of the vagina is the uretrosacral ligament and the transverse cervical ligament. Now, the level 2 or the middle 1/3 of the vagina is supported by the arcus tendinous fascia. So, a fascia is supporting the middle 1/3 of the vagina, just the arcus tendinous fascia. And the level 3 or the lower 1/3 of the vagina is supported by the perineal body and the perineal muscles which are attached to the perineal body, right? The perineal body and the perineal muscles which are attached to the perineal body. So level 1 is supported by uretrosacral and the cardinal ligament. Level 2 is supported by the arcus tendinous fascia. Level 3 is supported by the perineal body and the muscles which are attached to the perineal body. Is that clear? So these are the de Lancey's levels of supports of the vagina. Is that clear? Yes. So until now we have discussed that vagina has two important walls. Those are the anterior vaginal wall and the posterior vaginal wall. And we have three levels of vagina, where it is upper 1/3, middle 1/3 and lower 1/3. And what are the important structures which are supporting the vagina? Fine. So now as you can see here, we know that the vagina is divided into three portions, level 1, level 2 and level 3, or upper 1/3, middle 1/3 and lower 1/3. Now, we are going to see what are the defects which are actually caused by this vaginal prolapse. Fine. So let's take into consideration the anterior vaginal wall first, and then we will discuss about the posterior vaginal wall. So anterior vaginal wall we have divided into upper two-third of the anterior vaginal wall and lower one-third of the anterior vaginal wall. As you can see here, this is the anterior vaginal wall, and the anterior vaginal wall is taken into upper two-third portion and lower one-third portion of the anterior vaginal wall. So now you tell me, if the upper two-third of the anterior vaginal wall is going to be weakened, because of the weakness, it is going to get prolapsed. So what is the structure which is immediately near to the upper two-third portion of the anterior vaginal wall to herniate out? It is the bladder. As you can see here, the bladder is the structure which is immediately near to the upper two-third portion of the anterior vaginal wall. So urinary bladder is going to herniate through the upper two-third portion of the anterior vaginal wall because of the weakness. So if bladder is going to herniate out through the upper two-third of the anterior vaginal wall, it is called as cystocele. It is called as cystocele. Fine. Now, if the lower one-third portion of the anterior vaginal wall is going to get weakened and prolapse, what is the structure which is immediately near to the lower one-third portion of the anterior vaginal wall? It is the urethra. As you can see here, this is the urethra. So, if urethra is going to herniate through the lower one-third portion of the anterior vaginal wall, it is called as urethrocele, right? It is called as urethrocele. If anything is going to herniate, you used to call the term cele, right? So it is bladder is going to herniate, it is called as cystocele. Urethra is going to get herniate, it is called as urethrocele. Clear? Fine. Now, moving on to the posterior vaginal wall. So, with respect to the anterior vaginal wall, we have discussed two important things. That is the upper two-third portion, bladder herniate, cystocele. Lower one-third portion of the anterior vaginal wall, urethra is going to herniate, it is called as urethrocele. Now, coming to the posterior vaginal wall. This is the posterior vaginal wall. So in posterior vaginal wall, we are going to have it as upper one-third, middle one-third and lower one-third. See, the anterior vaginal wall, we held it as upper two-third and lower one-third. But posterior vaginal wall, you're going to have it as upper one-third, middle one-third and lower one-third. So it is upper one-third, middle one-third and lower one-third of the posterior vaginal wall. Now you tell me, if the upper one-third portion of the posterior vaginal wall is going to get weakened and it is going to be prolapsed, what is the structure which is immediately near to the upper one-third portion of the posterior vaginal wall? So it is the intestines. As you can see here, as I told you, the intestines will be present here. So the structure which are immediately near to the upper one-third portion of the posterior vaginal wall are the intestines. So intestine is going to herniate out through the upper one-third portion of the posterior vaginal wall. So if intestine is going to herniate, it is called as enterocele. It is called as enterocele. Fine. If middle one-third portion of the posterior vaginal wall is going to be weakened and prolapsed, what is the structure which is immediately near to the middle one-third portion of the posterior vaginal wall? It is the rectum. As you can see here, this structure is the rectum. So immediately near to the middle one-third portion of the posterior vaginal wall is the rectum. So therefore, the rectum is going to herniate out through the middle one-third portion of the posterior vaginal wall. And coming to the last portion, that is the lower one-third portion of the posterior vaginal wall, if it is going to be weakened and prolapsed, it is called as laxed perineum. It is called as laxed weakened perineum. Is that clear until now? Let me have a quick revision now. Anterior vaginal wall, upper two-third, lower one-third. Posterior vaginal wall, upper one-third, middle one-third and lower one-third. Upper two-third of the anterior vaginal wall, cystocele. Lower one-third of the anterior vaginal wall, urethrocele. Now, upper one-third of the posterior vaginal wall, enterocele. Middle one-third of the posterior vaginal wall, rectocele. Lower one-third of the posterior vaginal wall, it is called as laxed perineum. Is that clear until now? Yes, good, fine. So now we have learned about what are the structures which are going to be prolapsed out through the anterior and the posterior vaginal wall, right? So let me show you here. Right, if cystocele is going to be present, how it is going to happen is the bladder will be herniated out through this weakened upper two-third of the vagina and it will come out. Is that clear? Right. So through the weakened anterior vaginal wall and through the weakened posterior vaginal wall, the supporting surrounding structures are going to be herniated out. So it is basically because of weakness of the supporting structures which are supporting the vagina, the surrounding structures are going to be herniated out through the vaginal wall. Fine. Now, having discussed about what is vaginal prolapse and what are the defects which are caused and what those defects will lead to the prolapse of whatever structures which are immediately near to it, discussing about all those things, now we are moving to the symptom complex of this vaginal prolapse. So while discussing about the uterocervical prolapse, I told you certain particular symptoms which are important with restricted to uterocervical prolapse. But when taking into consideration the vaginal prolapse, we have many things like cystocele, urethrocele, enterocele, rectocele and lax perineum. So if urinary bladder is going to be herniated out, definitely symptoms which are related to urinary complaints will be present. If rectum is going to be herniated out, then definitely symptoms which are related to the rectum is going to be present, right? So we will be discussing it now. So what are the urinary complaints which will be anticipated? You need to ask about the frequency of urination, the urgency of urination, and if there are any dribbling of urine, recurrent urinary tract infections and lower abdominal pain. So because of cystocele, that is the urinary bladder getting herniated through the upper toothed portion of the anterior vaginal wall, the patient might have complaints like frequency of urination, urgency of urination, constant dribbling of urine, recurrent urinary tract infections, lower abdominal pain. So these are the urinary complaints which are related to cystocele. Right? These are the urinary complaints which are related to cystocele. And as far as rectum is concerned, as rectum is going to be prolapsed through the middle one-third portion of the posterior vaginal wall, the patient can present to you with constant difficulty to pass the stools, that they may have the symptom of incomplete evacuation of stools. So it is called as constipation. The patient will have difficulty in passing the stools, right? Incomplete evacuation of the stools. So the patient will present you with complaints of constipation also. And the patient might complain to you of low back ache, pelvic pressure and painful intercourse, dyspareunia and feeling a bulge in the vagina. So the patient may also complain to you that I'm feeling a bulge in my vagina. So all these could be the complaints a patient can present to you with, along with the complaints which we discussed in the previous module. That is, always uterocervical prolapse can be present along with the vaginal prolapse. So along with the uterocervical complaints, the patient may present to you with the vaginal complaints as well. So if a patient who is a known case of prolapse is having complaints related to urinary complaints or constipation or something like that, you also need to evaluate that patient for vaginal prolapse being present or not. Fine, because the risk factors are same for both the uterocervical and vaginal prolapse, right? So therefore, if uterus is going to be prolapsed, therefore there are increased chances for the vaginal prolapse as well. Fine. So now moving to the examination, what are you supposed to do? So similar to the uterocervical prolapse examination which we discussed in the previous module, you need to ask the patient to strain or cough. So once the patient is going to do Valsalva maneuver, the vaginal examination is going to be done with the patient in both the lithotomy position and with the patient in standing and squatting position. But with respect to vaginal prolapse, what are you going to do is you need to do perrectal examination also. So when you do the perrectal digital examination, a bulge will be felt in the fingers. But where the bulge is felt is very important. If the bulge is felt on the tip of the finger while doing the perrectal examination, it corresponds to enterocele. But if the bulge is felt on the pulp of the finger, it is called as rectocele, right? It will correspond to rectocele. So this is the finger, right? This is the pulp of the finger. This is the tip of the finger. If tip of the finger, it is enterocele. If the bulge is felt in the pulp of the finger, it corresponds to rectocele. Clear? Yes. And one important point is that many have a confusion that trans illumination test, where you're going to shine a torch and see for trans illumination, this test is positive in either enterocele or rectocele. It is positive in enterocele and it is negative in rectocele. Please remember, trans illumination test is positive in enterocele and it is negative in rectocele. And apart from that, additional investigations in cases of complex prolapse, you can do cystoscopy in order to evaluate the bladder to check for dribbling of the urine, and ultrasound can also be done, and magnetic resonance imaging can also be done in order to evaluate in detail in cases of complex prolapse. Is that clear now? Yes. Now, moving on to the management of prolapse. So until now we have discussed about the uterocervical prolapse, which is the descent of uterus and the cervix into the vagina, and in this model we dealt about the vaginal prolapse where due to the weakening of the vaginal wall, the surrounding structures can get herniated through the weakened vaginal wall, where we discuss about cystocele, urethrocele, enterocele, rectocele and laxed perineum. Now, while discussing about the management of prolapse, we are going to discuss about both the uterocervical prolapse and vaginal prolapse. But one thing to remember before starting about the management of prolapse is uterocervical prolapse, the management decision has to be taken depending on the age and the parietal status of the patient. How much is the parity of the patient, whether she has given birth to 2 live births or has she completed her family, has she not completed her family, what is the age of the female, you need to take into consideration, because you can't do any hysterectomy, you cannot remove the uterus in a patient who hasn't conceived yet at all, right? So in a reproductive age group female, you cannot remove the uterus because the patient might have not completed her pregnancy and she might not have any live birth child, right? So for that reason, you need to take into consideration the age and the parity of the patient. So uterocervical prolapse, age and the parity of the patient has to be taken into consideration, whereas in vaginal prolapse, age and parity of the patient is not important, right? So age and the parity of the patient needs to be taken into consideration in case of uterocervical prolapse, and in vaginal prolapse, the age and the parity of the patient need not be taken into consideration. What is parity? Parity is how much preterm labor she had, how much live birth she is having, how much abortion she had earlier, and the history, the obstetric history is corresponding to the parity, where you used to term like G2, P1, L1, right? So that is called as parity. How many children is she having, or whether she is a nulliparous female or she is a multiparous female. How many living children are present, how many abortions she had earlier, etc. So this depends upon the age and the parity of the patient. Fine. So now let's start with the uterocervical prolapse management. So when taking into consideration the management of uterocervical prolapse, we have both conservative management and surgical management. Out of the two, which is the best management? Surgical management is the best out of the two management. So conservative management is a management which can be done in the early stages of prolapse. Like in the first degree prolapse, conservative management can be done. So what is the conservative management? So conservative management can be like perineum supporting exercise, which is called as Kegel's exercise. Kegel's exercise is nothing but perineum supporting exercise. So these particular exercises are going to strengthen the pelvic floor muscle. See, the major problem with prolapse is because of weakening of the pelvic muscular support, pelvic muscular, ligamental and mechanical support. So if you are going to strengthen these pelvic floor muscles, then therefore the chances of prolapse will be less, and the chances of progression of prolapse will also be less. So for that reason, you need to advise the patient for perineum supporting exercise, that is the Kegel's exercise. So this exercise will strengthen the pelvic floor muscles. So as it is going to strengthen the pelvic floor muscle, this will prevent the prolapse, and it will also decrease the chances of progression of prolapse as well. So for that reason only, if a patient is going to deliver a fetus, both during the pregnancy and immediately after delivery of the fetus also, you need to advise the patient to do Kegel's exercise, which are basically perineum supporting exercise. So once the perineum is going to regain its strength after the delivery of the fetus itself, then therefore the chances of prolapse later in her life will be decreased, because the perineal muscles are already supported after each successful delivery the patient had. So for that reason only, we are advising females who are on pregnancy and who have delivered the fetus to do this Kegel's exercise, because doing this Kegel's exercise, it is going to support the perineal musculature. So once the perineal muscles are going to get strengthened, then the chances of prolapse will be decreased in such females. So conservative management consists of this Kegel's exercise, and it consists of a device which is known as pessary, which is called as pessary. What is pessary? So pessary is basically a space occupying prosthetic device. It is a prosthesis, right? It is a prosthetic space occupying device which is basically used for structural support. So the use of this pessary is not like your intrauterine contraceptive device. It is not going to release anything, but it is only used for a structural support. So what do you mean by structural support? If you're going to insert this pessary inside the vagina of the female, this pessary is going to held in place, and it is going to prevent the uterus and cervix to descend inside the vagina. So in the vagina, you're going to just held this pessary. So once you're going to put this pessary in the vagina, the uterus and the cervix will not descend further down into the vagina. So basically it is providing a structural support. But the main disadvantage with this pessary is that it has to be changed every 3 to 6 months or every 6 to 12 months in order to prevent infections. So in order to prevent the infection, this pessary has to be changed very frequently. Roughly around 6 to 12 months, this pessary has to be changed. And the most commonly used pessary are the gel horn pessary and the donut pessary. It is similar to donut, right? So it is donut pessary and this is the gel horn pessary. So gel horn pessary and the donut pessary are most commonly used pessaries, right? So this is basically a space occupying prosthetic device which is mainly used for structural support, and it is going to prevent the uterus cervix to descend down into the vagina. But the main thing is that it has to be changed every 6 to 12 months in order to prevent infections. Now, what is the use of this pessary? So this pessary can basically be used in pregnant female with prolapse. So if a female is there and she is pregnant now, and during pregnancy itself there is prolapse of the uterus in her. So as a clinician, you cannot do any definitive management during pregnancy, right? So during pregnancy, you're going to put this pessary inside the vagina, and this pessary will prevent the uterus and the cervix to descend down into the vagina. So prolapse in a pregnant female, prolapse in immediate postpartum period. So in the postpartum period also, you cannot do any definitive procedures, right? So in the immediate postpartum period also, this pessary can be used. And prolapse in elderly females such as more than 70 years of age, in elderly females, you can use this pessary. And in any patients there is contraindication to surgery, any history of contraindication to surgery is present, in that female also you cannot do any surgery. So just put this pessary inside the vagina, and this pessary is going to prevent the uterus to prolapse into the vagina. So this structure is basically going to support, as you can see here. Let me draw it here. So let me take into consideration, this is the pessary and this is the uterus and the cervix. This uterus and this is the vagina, and this is the pessary which is held in the vagina. So this pessary is going to prevent the uterus and the cervix to descend further down. So this is going to support the uterus and cervix and prevent it from further descent into the vagina. So therefore, with any patient with history of contraindication to surgery, therefore surgery cannot be done. So just insert this pessary into the vagina and ask the patient to come to change the pessary every 3 to 6 months or 6 to 12 months depending upon the type of pessary. And if the patient is not willing for any particular surgery, in such patients you can advise Kegel's exercise along with the pessary, right? So these are the conservative management in a case of uterocervical prolapse. So with respect to surgical management, which is the best management, and the management of vaginal prolapse, those will be dealt in detail in the next module. So I hope that this module is very interesting for you and we learned many new and important things in this module. If you have any doubt, please write to me in the Mackler Gmail handle. I will write out to you as early as when possible. And please subscribe to Mackler YouTube handle